Hello and welcome to our last video on alterations of musculoskeletal function. In this video, we are going to discuss musculoskeletal tumors, starting with bone tumors here. Now, primary bone cancer is rare and metastatic disease is more common in bone, and our bone tumors are going to be classified by tissue of origin with four main types. And the four types are going to stem from our primitive mesodermal cells. So I really liked this figure over here, and it breaks it down into talking about our osteogenic types that originate from our bone forming cells, the osteoblasts. We also have our chondrogenic tumors that are arising from our cartilage forming cells, the chondroblasts, that produce a cartilage-like substance. And then we have our collagenous, which is going to be derived from our fibrous tissue cells, producing collagen-like matrix. And lastly, we have our myelogenic that develop from bone marrow elements. Now, we can also have classifications include tumors of histiocytic, notochordal, lipogenic, and neurogenic origin based on their cellular lineage. Now, when we classify tumors, it will include benign or non-invasive and malignant or invasive tumors. But we're going to focus here on our malignant bone tumors. And these cells are going to show increased nuclear to cytoplasmic ratio. And you could see that pictured over here where our nucleus is much larger than the cytoplasm. We'll also have irregular borders and excess chromatin. And the main function of chromatin is to package our DNA into a unit capable of fitting within the tight space of the nucleus, right? And then a prominent nucleolus, so you can see the nucleolus here is quite large, and an increase in our mitotic rate. So we will have a lot more proliferation of these cells. Now, when it comes to the epidemiology, we are going to have osteosarcoma as our most common primary malignant bone tumor in children and young adults. And our bone tumors are most common in adolescents in general. And then we see an increase in frequency after the age of 35. And this is largely due to metastatic disease. Now, our benign tumors push against bone tissue and cause compression, and this can lead to pathologic fractures. Our malignant tumors are going to invade bone and stimulate the osteoclast or disrupt blood supply that can then cause destruction. And there are three patterns of destruction. First, we have our geographic pattern, which you can see pictured over here. You can see that it's localized, and we have these well-defined margins on the tumor, and it is easily separated from the surrounding normal bone. And this tends to be least aggressive and is slow growing. Next, we have our moth-eaten pattern in the center over here, and we could see multiple areas of destruction here, and this tends to be more aggressive. We see that it rapidly grows and is a malignant tumor in which the margin is less defined or demarcated. And lastly, we have our permeative pattern. This is poorly defined and spreads aggressively and has a rapid growth potential. Now, the symptoms of this are going to be attributed to trauma, degenerative changes, or inflammation. And so our symptoms may be vague because it could be confused with trauma, inflammation, or the degenerative conditions. But we know that early diagnosis is going to be critical for survival and limb preservation. So we can use things like imaging, like an MRI, CT, bone scan, or X-ray. and use laboratories for us to look for things like serum alkaline phosphatase. We can look at a CBC and ESR to rule out infection or hematologic malignancy, our serum calcium, phosphorus, glucose, acid phosphatase for metabolic clues, and a protein electrophoresis so we can rule out multiple myeloma. And lastly, we could do a biopsy using a fine needle or surgical biopsy so that we have a definitive diagnosis and can plan for treatment. So we'll first talk about osteogenic tumors, and osteosarcoma is the most common malignant bone-forming tumor, and it's characterized by the production of osteoid by anaplastic stromal cells within the sarcomatose stroma, and it's an aggressive primary bone cancer with a high risk for adolescents and young adults. And we see a secondary incident peak in older adults with prior radiation exposure. So most commonly, we see it in individuals under 20 years of age. Approximately 60% of the cases are in this age range. And then we see a second peak in adults over the age of 60, especially post-radiation therapy. We do see it's more common in males as well, and it accounts for a large proportion of primary malignant bone tumors. Now, as far as where we find it, it typically arises in the metaphyses of the long bone. So that's kind of where we have the junction of, I don't know what picture is best to use, but the junction of the epiphyses and the diaphyses is where we're going to find that metaphysis, and that's in about 90% of cases. And 50% of cases are found around the knee, especially in the distal femur, like we see pictured over here, and the proximal tibia. And it often leads to periosteal lifting, creating new and abnormal bone. So digging into the pathophysiology, we'll see that it's composed of the anaplastic stromal cells, like I mentioned before, that produces the osteoid. And that can include chondroid or fibrous components as well. And that osteoid appears as these thick streamers that infiltrate and destroy normal bone. And some of the radiologic features we'll see is that moth-eaten bone destruction and the poorly defined margins that blend into the adjacent bone. And we see cortical destruction. So remember on the peripheries where we find that that compact bone, and we also see an extension into the soft tissues. So typically we can have a periosteal reaction, which signals for us some rapid growth. As far as clinical manifestations, we'll have localized bone pain that's typically worse at night. You'll see some swelling over the affected area and sometimes some pathological fractures. To diagnosis, you can kind of see the imaging taking place here, but we could do an X-ray, MRI, a bone scan to reveal the cortical destruction and look for periosteal reaction and some soft tissue masses. We can also take a biopsy to confirm the diagnosis through histological identification of those osteoid-producing malignant cells. Now let's talk about chondrogenic tumors. So we'll discuss chondrosarcoma, which is the second most common primary malignant bone tumor. And this typically occurs in middle-aged or older adults and peaks around the sixth decade of life. And we see it's more common in men. So this can develop from a pre-existing benign lesion, something called a enchondroma, which is known as a secondary chondrosarcoma, and this is rare and typically occurs in younger adults. But as far as the pathophysiology, we'll have infiltration of the trabeculae in the spongy bone. You can kind of see that pictured along in here, and frequently it's in the area of the metaphysis or the diaphysis of our long bones. So areas like the femur and the proximal humerus, which is pictured over here, and the pelvis. And it can also invade nearby tissues, which can lead to tumor seeding. Now, for clinical features, it will be a slow, insidious onset that will present with like a local swelling and dull, intermittent pain that gradually starts to become constant and worse at night. To diagnose this, we want to use radiographs and biopsy, and typically the primary treatment is going to be surgical excision, as chemotherapy and radiation, unfortunately, are pretty ineffective. Next, we have our collagenic tumors, and fibrosarcoma is our tumor that is going to form fibrous connective tissue, and it's the most common type and can affect bone and or soft tissue. We see that it creates this firm fibrous mass of collagen and malignant fibroblasts and osteoclast-like giant cells. We see it's most common in adults between the age of 30 and 50, and we see a slightly higher incident in females. Now, the way that this develops is it arises from the fibroblasts, which are derived from the mesenchymal stem cells. And usually we have just the solitary tumor and find it in the area of the metaphysis of the femur or the tibia. So here in this image, this is the tibia, believe it or not. And right here would be like the head of the fibula. And it's composed of malignant fibroblasts, collagen, and those osteoclast-like giant cells, as we said. It can start in the marrow cavity and infiltrate the trabeculae and start to destroy the cortex and spread into the soft tissue areas. And this frequently metastasizes to the lungs as well. So to diagnose this, we want to use a radiograph and MRI, and then for treatment, we would do radical surgery or amputation. Unfortunately, once again here, radiation therapy is typically ineffective. We have myelogenic tumors, and these are going to originate from various bone marrow cells. And we have two main types. We have the giant cell tumor and a myeloma. And it typically happens in adults that are between the ages of 20 and 40 years old. And we see that it's more frequent in females. The pathophysiology here is that we generally are going to start off benign as a solitary tumor that's well circumscribed and originates from the osteoclastic cells, causing extensive bone resorption. So you can see some of that bone resorption taking place over here, and it commonly affects the epiphysis of our long bones in areas like the femur, tibia, radius, and the humerus. And it could lead to pathologic fractures and involvement of the articular cartilage. And these clients typically will experience pain, local swelling, and limited joint movement. And to diagnose it, we're going to want to use radiographs, CT, and MRI. For treatment, we would use cryosurgery and a tumor resection. We can also use PMMA bone grafts. I'm going to try and pronounce this all in one time, but PMMA stands for polymethyl methacrylate, and is a type of bone cement that usually they use in orthopedic surgeries, and it helps to lower the recurrence rate. So amputation is rare, as hopefully surgery will take care of the issue. And the last thing we're going to talk about are muscle tumors, and these are rare. And our rhabdomyoma is a rare benign tumor of our striated muscle. Typically, we're going to find it in the areas of the tongue, neck, muscles, larynx, uvula, nasal cavity, axilla, vulva, and the heart. And to treat it, we will do surgical excision, and so the recurrence rate is rare. And the malignant version of this would be called a rhabdomyosarcoma. Now, the rhabdomyosarcomas are also rare, and the most common soft tissue sarcoma in children and adolescents. It makes up about 50% of all of the soft tissue sarcomas and 10% of all malignant tumors in children. So these tumors are unfortunately aggressive and can rapidly metastasize and primarily occur in the head, neck, GU tract within 75% of cases, and the rest of the percentage will take place in the trunk, extremities, and the urinary tract. The anaplastic spindle cell type that you could see pictured over here is considered one of the most highly malignant tumors of the extremities that we see in adulthood, whereas some of the others, like the microscopic ones, like the embryonal tumors, resemble a tadpole or a tennis racket and are most often seen in infancy and childhood. We have our alveolar type of tumor that is a lattice type of appearance that's similar to lung tissue of the alveoli and are typically found in adolescents and in adults. And to diagnose these, we want to involve a history, physical examination, and imaging like CT or MRI, and a biopsy. We would want to stage the tumor. Then for treatment, we would use a combination of surgical excision, chemotherapy, and radiation. And luckily, the prognosis is better in children, with survival rates improving over time, while the adult survival remains poor.